Good afternoon. My name is Dr. Clement Nzuka. I am here again to highlight how HIV has changed the face of medicine. Today, I'm gonna look at the development of a cancer of the cervix. How does it develop? What causes it? You know, we always talk of HIV, some other thing that is going with HIV. We have now human papillomavirus. Human papillomavirus, we look at it as a causative agent or as an etiological agent of the CA of the cervix or the cancer of the cervix. HPV, when it is abbreviated, HPV, human papillomavirus, has got, we cannot look at it as something that is homogeneous. It has got different types. We can comfortably look at it as being heterogeneous because it has got different types. And these types are divided into low risk and high risks, the types. For instance, we talk of subtype 16. We talk of type 18. We talk of 35. We talk of 53. All those, we often see them with high risk. High risk. We call them high risk types. And you go down to things like types like 11, well, a number of others regarded as low risk. But what we see, which is worth taking note of, worth considering, is the fact that when this HPV is co-infected with HIV, the numbers of HPV, they tend to be higher. I mean, we're comparing two types of patients, an immunocompetent patient and an immunocompromised patient. An immunocompromised patient is the patient that's represented by, we're talking of it's immunocompromised by HIV in this case. So we look at the numbers now of the HPV viruses. They tend to be high with HIV-infected patients. They tend to be high as opposed to HIV-negative patients. So HPV, let's get this one straight. HPV will infect an immunocompetent patient. HPV will infect an immunocompromised patient. But if you look at the rates and the levels of the actual viruses, they tend to be higher with HIV-infected patients. And there's something as well that we note. This cancer of the cervix we were looking at a particular area. From the vagina and then to the entry of the uterus. This region in between, that's the one that's called the cervix. And if we look at the histology of this area, we look at two types of cells, the columnar cells and the squamous cells. So it's a squamo-columnar junction. And if we look at this, we look at the histology, we notice that these cells here are specific cells which are highly mitotic. Those mitotic divisions, remember when we talk of divisions, we always think of meiotic divisions and mitotic divisions. Mitotic divisions are those for growth. This human papillomavirus tends to infect these mitotic cells, this region of mitotic cells, and it will infect it and it will go straight to the nucleus so that it should be replicated. It will go straight to the nucleus. And so they are always found in the nucleus of these mitotic cells in this region. They call it, shall I say, a zone where there are just mitotic cells. And these mitotic cells, now, they are changed in a market. There's no way that you will not notice this. They are markedly changed by co-infection with HIV. When there's HIV co-infected with human papillomavirus, we said the numbers of HPVs, they go up. And now they attack this area, this junction. This, we call it the squamo-columnar. You've got columnar cells and you've got squamous cells. And this junction is the one that has got these mitotic cells, and which are the targets of HPV. Now, what we notice with this junction, what we notice with this infection by HPV, there's something you will not miss. One shows regression. If you have a patient who is negative for HIV, an HIV negative patient, you'll find that this patient will be infected by HPV, but that HPV is regressed, and then suddenly you don't see it because of regression, because the patient is immunocompetent. So the immune system of the patient helps the patient to regress this infection. When it was there, it's out, it gets flushed out. This is important. Whereas when there's HIV infected patient and an infection by this human papillomavirus, you see progression. So there are two antagonizing processes here: regression and progression. With HIV, there's progression. With HIV negative patients, there's regression. This is something to take home. That's something to take home. There's regression because of this important thing that needs to be understood and really to be taken serious. One has to take this one seriously. This junction has got cells, has got, in fact, proteins, which are suppressor proteins. Suppressor proteins. Is it good to suppress? Suppression is actually good now because you're suppressing, you've got proteins which suppress tumor development. You know, tumor development is suppressed by these tumor suppression proteins. And this is something that you notice with immunocompetent patients. They've got tumor suppressor or suppression genes or proteins. You know, genes, of course, will make, RNA, and RNA will make a protein according to the central dogma of molecular genetics, as we said. Right. So these proteins, what is important about them is that they suppress tumor development. You know, I have to take you a little bit back. When I speak of tumor development, one of the characteristic features of inflammation is tumor, which is tumor development. Rubor, which is redness. Color. You know, when a tissue is damaged, it gets red. That's a show that it is actually damaged. It goes red. So rubor, that's a feature of inflammation. Color, development of heat. These patients, they develop a fever because it's a feature of inflammation. These patients, like I say, they develop a tumor. Tumor is swelling. I mean, how you notice that there's a problem with this regional area, this transitional area. It's called a transitional area. This cervix, which is a transitional area. It's when there's a development of a tumor. And that's when you say, what's going on here? What's going on here? Is this a cancer already? That's when you do biopsy and you check and you send it to the lab, that biopsy to the lab, and then they will say malignant, or they will say, oh no, it's non-malignant. Of course, cancer of the cervix is malignant, kills the patient. So what I want you to notice is that it is a product of inflammation. We said calor, fever. They develop a fever, these patients. Dolor is a pain. This patient is painful. Everything is painful. When they actually have it's painful. Dolor, that's a pain. Tumor, a tumor development. These are the characteristics, and this is what we notice with these patients in this transitional zone. The cervix. This transitional zone, the cervix. And when there's this co-infection, HIV and HPV being human papillomavirus. This is very good to know. It is good to know how HIV changes. It changes everything. We had an immunocompetent patient here. the immunocompetent patient was able to flush out this HPV when it comes in, when it infects the area, this zone. This zone will always be infected because, I mean, the nucleus is there of all these, and it targets the nucleus because that's where replication will take place. So it targets the nucleus. So the nucleus of these transitional cells, the transitional region. And so this is where the problem is. The problem is when there's HIV, the regression that we're excited about is no longer there. What do we see? It is replaced by what? By progression. This is when HIV changes a situation that we know so very well. Well, we have been getting patients. You know, first of all, that regression is counteracted in the case of an HIV-infected patient by the persistence of this HPV in that area, that is in the transitional zone, in the cervix. Persistence. It persists to be there instead of being flushed out. It will persist and persist and persist being there. But it will start now infecting other cells in the cervix, other cells in the cervix. So the infection is growing instead of diminishing. Like in the case of HIV negative patients, this doesn't take place. The HPV is being flushed out. It gets cleared, literally cleared. But once there's co-infection with HIV, you see persistence of this HPV in this region. Persistence, infecting other cells. And you know, this region consists of two types of, shall I say, we know that there are two types. There are those two types of, two groups of these HPV types. There are those which are regarded as low risk. There are those which are regarded as high risk. High risk going towards cancer formation. So now, when the patient gets infected with HIV, it changes those which were low risk, they progress to high risk. And those which are high risk, they progress to cancer of the cervix. And this is something to be noticed. And this is something to be noticed. What can we do to try and prevent this? First of all, let's try to make sure that we use condoms so that we don't get HIV. I mean, that one is clear. We've got to make sure that we don't get HIV. We need to make sure that, all right, HIV, is that the only thing that we can do? What about vaccination? We can vaccinate the patients. Cervical, you know, the Cervirax vaccine. Cervirax vaccine is good. It can be used. In fact, you go to the clinic, they've got different types of these vaccines. They'll give you, okay, Cervirax. They'll give you Cervirax, whatever is there, right? And to try and prevent this, I believe even with school kids now, they are encouraged to go to clinics so that they can be vaccinated against HPV. I think that's one of the best things that needs to be done. You make sure that we vaccinate people before they actually get even infected with HIV. Because when they are infected with HIV, there's a big problem now, because now there's this progression that we are talking about as opposed to regression. This progression to CA of the cervix. This is a problem. And I can tell you, if we are not careless with how we go around this, because the risk factors are these multiple sex partners. Those are the risk factors. And you don't use preventative methods. You know, those are the risk factors of getting HIV. We know HIV is going to accelerate the infection of HPV. HPV, once there's HIV, that partnership is a very bad partnership. And we need to make sure that we safeguard these women, that they don't get the cancer of the cervix. I want to say thank you very much for listening to me today. I need that we make sure that we know something about the prevention of the development of cancer of the cervix. It's actually, the Center for Development of Infectious Diseases, or Control of Diseases, Center for Development of the control of this. They use the presence or the diagnosis of cancer of the cervix as an AIDS defining condition. It's an AIDS defining condition. For instance, all patients whose CD4 count is less than 200, it's a problem. That's AIDS already. And so we don't want our women folk to fall victim to a situation like this. The only way is vaccination. The only way is the use of condoms. The only way is to try and avoid this multiple partner thing that has become so popular, to make sure that there is no cancer of the cervix. So cancer of the cervix is actually associated much with HIV. It's actually prevalent now. This is something that it's avoidable. We are by no means saying that immunocompetent patients do not get cancer of the cervix. But what we know is that after infection, it is flushed out. It is cleared. After infection, it is cleared. Most of the time, it is cleared because of this regression, right? And in HIV, what we need to know and take home and encourage our youngsters to go to the clinic and be vaccinated against HPV is because we know that there's progression from a low risk group to a high risk group. That high risk group will go to cancer of the cervix, and that is avoidable. We can always avoid that. Thank you very much for that. Thank you very much. And I will come with another topic that makes sure that we understand that that HIV has really changed the complexion of medicine. And look at this one. This is a very good example. And I would like you to encourage people and make sure that you're not doing it to please anybody, but you're doing it to make sure that your life is well looked after. Thank you very much.